Okay, so you've probably seen this, right? Your dog, maybe your cat, finishes a meal, maybe a bit too fast, and then, well, pretty quietly, the food just sort of reappears.
Mm-hmm.
And most of us, our immediate thought is vomiting. That's the word we use.
It is. It's the common term.
But what if it's actually something totally different? And what if knowing that difference is like the absolute key to figuring out what's really wrong?
That's exactly the point. That distinction is hammered home in the sources you gave us for today's deep dive. Getting clear on whether it's vomiting or this other thing, regurgitation, well, that's step one. It's fundamental.
Right. And that's what we're getting into today. We've got this pile of veterinary texts, study guides, all focused specifically on regurgitation in dogs and cats, all from you.
Yep.
And our job is to unpack it all, find the really crucial bits, and help you understand what regurgitation actually is, why it happens, and what it all means for diagnosis and care.
We'll follow the map these sources lay out from that thing you see at home, right through the biology, the causes, how vets figure it out, and what can be done.
Okay, let's dive in. The sources really kick off with this regurgitation versus vomiting thing. It's the big aha moment. So based on this material, what are we actually looking for? How do we tell them apart?
Well, the core difference the texts highlight is the process. Regurgitation, it's described as passive, effortless almost.
Passive.
Yeah, you typically don't see that intense abdominal squeezing, that heaving motion you expect with being sick. And crucially, the sources stress there's often no warning, no pacing, drooling, retching beforehand. That's the prodromal phase, and it's usually absent. It just happens.
Like it just kind of slides back out.
Okay.
Whereas vomiting, the sources say, is definitely active, forceful.
Very active. You see the abdominal effort, and usually the animal acts nauseous beforehand, maybe pacing, drooling, looking distressed. That's that prodromal phase they mentioned.
Got it. And what about the stuff that actually comes up? The sources say that can be a clue, too.
It can, yeah, although observing the event itself is more reliable than just looking at the mess afterwards, the texts caution.
Right.
But with regurgitation, you're typically seeing undigested food. It might even look kind of tube-shaped, from the esophagus.
Okay.
And it's usually just coated in saliva or mucus. Importantly, there shouldn't be any bile, that yellow-green stuff. And the pH alkaline.
Okay, so if it looks almost exactly like it did going in, just maybe a bit slimy, that points towards regurgitation.
Strong indicator, yes.
And with vomiting, the sources say it's often partly digested, maybe has that bile mixed in, gastric fluids.
Exactly. It's often more broken down, might have that yellowish or greenish tinge from bile, and it's acidic because it's come from the stomach.
Acidic versus alkaline.
Yeah.
Got it. And timing, does that play a role?
It can help, though. Again, seeing it happen is best. Regurgitation tends to occur pretty soon after eating or drinking. Could be minutes, maybe up to a couple of hours. Vomiting, on the other hand, can happen much later, sometimes hours after a meal, once things have started moving into the stomach and intestines.
This distinction, it sounds absolutely critical for the vet. Why is getting a video, like the sources suggest, so helpful?
Oh, it's huge, because it immediately tells the vet where to start looking. If you can confirm it's true regurgitation, the problem is almost certainly upstream in the pharynx, the throat area, or much more likely the esophagus. Food isn't getting down.
Right.
If it's vomiting, the issue is likely lower down stomach, intestines, or maybe something systemic, even a brain issue affecting the vomit center. It completely changes the diagnostic path.
Makes total sense, like figuring out if the blockage is in the sink drain or further down the pipes. Yep. So if regurgitation is this passive return of stuff, what's actually going wrong inside? The sources seem to point to a failure in how the esophagus works.
That's the core issue described, yes. Normally, when an animal swallows, it triggers sensors in the throat and esophagus. Signals zip up nerves. They specifically mention the vagus and glossopharyngeal nerves to a control center in the brainstem.
Okay.
Then motor signals come back down, mostly via the vagus nerve again, telling the esophageal muscles to contract in this coordinated wave, pushing the food down. That wave is called peristalsis.
Ah, peristalsis, that muscular squeeze like getting toothpaste out.
Exactly like that.
Yeah.
And the sources really emphasize that if there's a problem anywhere along that nerve pathway, the sensors, the nerves going up or down, the brainstem processing, or the muscles themselves that wave, that peristalsis can fail.
So the squeeze doesn't happen right.
Right, or it's weak or totally absent, so food just sits there in the esophagus, piles up, and eventually passively comes back out.
Okay, failure of the downward movement. Now, The sources spend a lot of time detailing the causes of this esophageal failure. They break it down, like things pets are born with versus things they develop later, and whether it's a throat problem or an esophagus problem. Let's start with the big one the sources identify. Megaesophagus.
Yeah, Megaesophagus is definitely highlighted. It's called the most common cause of regurgitation, especially in dogs. It basically means the esophagus is dilated, stretched out, floppy. It lacks that muscle tone and coordinated movement.
Like the toothpaste tube when all loose and baggy.
That's a good visual, yeah. The squeeze is gone.
And this could be congenital, born with it, or acquired, develops later.
Both. Congenital megaesophagus shows up in young puppies, often right around weaning when they switch to solid food. The most common type mentioned is idiopathic.
Idiopathic meaning
Yeah,
we don't know the exact cause.
exactly. Unknown cause. Suspected to be a developmental issue with the nerves or muscles, maybe genetic in some breeds.
Got it. Puppy starts solids. Has trouble. What's the other congenital one mentioned? Vascular ring anomaly. That sounds structural.
It is. It's a fascinating one. Basically, some blood vessels that should have disappeared during development stick around and form a ring around the esophagus, physically pinching it.
Wow. Okay.
The most common type noted is a persistent right aortic arch. It creates this bottleneck, and the esophagus upstream gets stretched out. Like the idiopathic form, it usually shows up at weaning, and surgery is often the fix here.
A literal squeeze from a blood vessel.
Yeah, okay.
Now, acquired megaesophagus, the type seen more in adult dogs, the sources say this can also be idiopathic. No known cause found.
Correct. Acquired idiopathic megaesophagus is what's left after you rule everything else out. But, and this is where the sources get really clinically important, acquired megaesophagus can often be secondary to other underlying diseases.
So it's a symptom of something else going on.
Precisely. And finding and treating that underlying condition can sometimes resolve the megaesophagus, which is huge.
Okay, so what are some key examples the sources give? They mention myasthenia gravis, and it's often treatable.
Yes, myasthenia gravis is a big one to look for. It's an immune system disorder attacking the nerve-muscle connections. If it hits the esophagus, you get profound weakness and poor motility. Finding and treating MG can make a massive difference.
That's hopeful. What else?
Other systemic issues listed include hypoadrenocorticism, that's Addison's disease, an endocrine problem.
Addison's? Okay.
Hypothyroidism is mentioned, though the sources suggest it's maybe less commonly a direct cause. Then there are rarer but serious things like dysautonomia, which affects the autonomic nervous system, various other nerve and muscle disorders, polyneuropathies, polymyopathies, and even toxins like botulism or lead poisoning.
Wow, quite a list of potential culprits.
It really shows how the esophagus can be affected by problems elsewhere in the body. The sources also add that really bad or chronic inflammation of the esophagus itself, esophagitis, or even a partial blockage over time, can eventually damage the esophageal wall and lead to acquired megaesophagus too.
Okay, so megaesophagus is the picture of the big, floppy esophagus. But the sources also talk about other specific esophageal issues causing regurgitation, like that inflammation, esophagitis itself.
Right, esophagitis, inflammation of the lining. The texts list several causes for that. Gastroesophageal reflux, or GERD, stomach acid splashing back up.
Like heartburn in people?
Sort of, yeah, but it can cause significant damage in pets. Also, foreign bodies stuck in the esophagus can cause inflammation. Ingesting caustic things, and a really interesting one, especially noted for cats, pill esophagitis.
Pill esophagitis from medication.
Yes. If a dry pill, especially certain types like doxycycline, gets stuck in a cat's esophagus and dissolves slowly, it can cause severe local irritation and burns. Something for cat owners giving pills to be aware of. There's also a rare parasite, Spirocirca lupi, mentioned for dogs.
That pill detail is really practical and kind of scary. What about physical blockages? Not necessarily megaesophagus, just blocked.
Obstructions, yeah. Another major category. Strictures are mentioned. These are narrowings, usually scar tissue from prior severe esophagitis or maybe trauma.
Scar tissue tightening things up.
Exactly. Then actual foreign bodies, bones, toys, things that get lodged. Neoplasia tumors, either growing inside the esophagus or pressing on it from the outside. And hiatal hernia.
What's that again?
That's where part of the stomach actually slides up through the diaphragm into the chest cavity. It can cause obstruction and often leads to bad reflux and esophagitis.
Okay, lots going on in the esophagus itself. What about higher up? The pharynx, the throat area where swallowing starts?
Pharyngeal disorders, yeah. Problems with that initial voluntary part of the swallow. Could be pharyngeal weakness or dysfunction, often neuromuscular again,
Mhm.
or a specific thing called cricopharyngeal dysphagia.
What's that?
It's where the muscle right at the top of the esophagus, the cricopharyngeal muscle, fails to relax properly to let food pass through when the animal tries to swallow.
So the door doesn't open right.
Pretty much. Or you could have masses, tumors in the pharynx blocking the way.
And the sources make a point about aspiration risk with these pharyngeal issues.
Yes, a critical point. If that initial swallow mechanism is faulty, the airway might not be protected properly when they try to swallow or regurgitate, making it much easier for food or liquid to go down the wrong way into the lungs. Higher risk than with just esophageal problems.
Makes sense. Okay, beyond these specific areas, the sources briefly touch on some other systemic diseases, like muscle inflammation, lupus.
Right, things like polymyositis, systemic lupus, erythematosus, sometimes thymoma, a tumor of the thymus gland.
Hmm.
These can indirectly impact esophageal muscle function or nerve control as part of a wider disease process.
Got it. Now, here's something the sources always include that listeners might find interesting: breed predispositions. Are certain breeds more prone to this?
Oh yes, definitely. The data points that way, especially for Megaesophagus, the congenital form. Wire-haired fox terriers and miniature schnauzers are specifically called out with known genetic links. Other dog breeds listed include Great Danes, German Shepherds, Irish Setters, Labs, Newfoundlands, Boxers, and interestingly, several brachycephalic or short-nosed breeds.
Like pugs and bulldogs.
Exactly. Shar-Peis, pugs, Boston Terriers, English Bulldogs, French Bulldogs are all mentioned.
That's quite a list for dogs. What about cats?
For cats, the sources specifically point to Siamese and related breeds as having a predisposition.
Interesting. Okay, so we've got the difference between R and V, the why it happens, that motility failure, and this whole range of potential causes from the sources. What else might you, the owner, actually see besides just the food coming back up? What other clinical signs are described?
Well, very commonly you'll see weight loss, sometimes pretty dramatic weight loss because nutrients just aren't getting absorbed.
Because the food isn't staying down.
Exactly. Dysphagia is another common sign that means difficulty swallowing. You might see them trying multiple times to swallow, gagging, seeming uncomfortable when they eat.
Coughing too.
Yes, coughing or gagging, especially right after eating or drinking, is pretty typical.
And because they're not getting those calories, they might seem extra hungry.
Totally. A ravenous appetite is often reported. They're hungry. Their body knows it needs food. Other things mentioned are tyolism, that's excessive drooling.
From irritation, maybe?
Likely, yeah. Irritation or pain in the esophagus. And halitosis, bad breath. That comes from food just sitting and fermenting in a dilated esophagus.
Ugh, okay. And then the big, scary complication we mentioned.
Aspiration pneumonia. Yeah, this is the one vets worry about most. It happens when that regurgitated stuff gets inhaled into the lungs.
And the signs for that.
The sources list things like coughing, definitely, but also fever, lethargy, just seeming really unwell, difficulty breathing, maybe nasal discharge. It's serious, a medical emergency.
Okay. So you notice what looks like regurgitation, maybe some of these other signs.
Yeah.
What's the vet's process then? How do they narrow down the cause? The sources are clear. Regurgitation is a sign, not the final answer.
Absolutely. Investigation is key. And it starts, like we said, with getting that detailed history from the owner, really pinning down if it's regurgitation or vomiting. That owner observation, or even better, a video, is invaluable.
Right. Video helps a ton. Then the physical exam?
Yep. The vet will check overall condition, body weight, look in the mouth and throat, feel the neck area, listen carefully to the chest for any crackles or sounds suggesting pneumonia, and maybe do a neurological exam if they suspect a nerve or muscle issue.
Okay. Then imaging sounds crucial. X-rays.
Plain x-rays, yes, often the first step. They can sometimes show that classic dilated air or fluid-filled esophagus of Megaesophagus. They might also spot a foreign object, a mass, or see those lung changes of aspiration pneumonia.
But sometimes plain X-rays aren't enough to see the details, so the sources mention contrast studies.
Right. A barium swallow is a really important tool here. The pet swallows liquid barium or maybe food coated in barium, and the vet takes x-rays as it goes down.
But watch it move.
Exactly. It outlines the esophagus beautifully, shows dilation clearly, helps assess how well it's moving, or if it's moving at all. It can highlight strictures, masses, little pouches called diverticula, or that pinching from a vascular ring anomaly.
Many downsides.
The sources do mention being cautious, as there's a slightly increased risk of the pet aspirating the barium itself, especially if they're already prone to it.
Okay. And for seeing the actual function in real time, the sources called something the gold standard.
Video fluoroscopy. Basically, it's a moving X-ray, a video, taken while the animal swallows barium. It lets the vet watch the whole swallow process dynamically, assessing both the pharyngeal part and the esophageal motility. It's great for subtle motility issues.
Gotcha. And sometimes CT or ultrasound for tricky things like masses.
Yes, they can provide more detailed images of specific structures if needed.
What about actually looking inside the esophagus
That's endoscopy, specifically esophagoscopy. A flexible camera goes down the
to
esophagus.
see what's going on directly?
Exactly. Look for inflammation, esophagitis, see strictures, find foreign bodies, spot masses. Plus, you can take biopsies through the endoscope or even use it therapeutically, grab a foreign body, or use a special balloon to stretch open a stricture.
Okay. And finally, blood tests. Lab work. The sources say these aren't for diagnosing regurgitation itself, but for those underlying causes.
Precisely. Routine blood work, like a CBC and chemistry panel, might show inflammation or electrolyte changes hinting at Addison's, or signs of infection from pneumonia, but often you need more specific tests.
Like for myasthenia gravis.
Yes, the acetylcholine receptor antibody test for MG, or an ACTH stimulation test for Addison's. Thyroid hormone levels for hypothyroidism, maybe even lead levels if that's suspected. These lab tests are critical for finding that treatable underlying why.
Okay, so after all that digging, guided by knowing it's regurgitation, you hopefully have a diagnosis. What can actually be done? What do the sources say about treatment and management?
Well, the number one goal, according to the sources, is always treat the underlying cause if you found one and if it's treatable.
Right. Fix the root problem if possible. But for things like that common idiopathic megaesophagus, where there isn't a root cause to fix, supportive care sounds absolutely vital.
It is. It's everything, especially since megaesophagus often means lifelong management. And the single most important part of that, stressed repeatedly in the material, is elevated feeding.
Feeding them upright.
Yes, the pet has to eat and drink in a vertical, upright position. You need gravity to help get that food and water down into the stomach.
How upright? Like sitting.
Pretty much vertical. And they need to stay that way for a good 10-15 minutes after they finish eating or drinking to let everything settle down.
That sounds demanding.
It is. The sources even mention specific devices like the Bailey chair for dogs. It's basically a special high chair designed to keep them comfortably upright for feeding. It really illustrates the level of commitment needed.
Wow. A Bailey chair. What about the food itself? Does consistency make a difference?
Huge difference. And the sources say it requires experimentation. What works for one pet might not work for another.
Like liquid versus solid.
Yeah. Some do best on a thin liquid gruel. Some need thicker, almost meatball consistency food that they can kind of plunge down. Others might need a blenderized slurry. You have to find what works for that specific animal. And feeding smaller meals more often usually works better than large ones.
Okay. And managing that scary complication, aspiration pneumonia.
That requires immediate veterinary care, aggressive treatment. Antibiotics are key, often broad spectrum at first, then may be adjusted based on culture results.
What else?
Oxygen therapy if they're struggling to breathe, IV fluids for hydration and support. And sometimes, if aspiration keeps happening despite upright feeding, the sources mention considering a feeding tube, like a gastrostomy tube that goes directly into the stomach, to bypass the esophagus altogether while the lungs heal or long term.
Right. Bypass the problem area. And then for those cases where there is an underlying cause you can treat.
Then you target that. Surgery, as we mentioned, for vascular ring anomalies or to remove foreign bodies. Endoscopic balloon dilation to stretch strictures. Specific drugs for myasthenia gravis, Addison's, hypothyroidism. If it's reflux esophagitis, maybe acid reducers like omeprazole or famotidine, or drugs to help stomach emptying like metoclopramide or cisapride.
So with all these different causes and approaches, what's the general outlook, the prognosis for a pet with regurgitation?
It varies massively, as you'd expect, depending entirely on the cause. If you find a treatable cause early, like a vascular ring anomaly fixed surgically, or MG or Addison's that responds well to meds, the prognosis can actually be quite good. The regurgitation might even resolve completely.
That's great news for those cases. But what about idiopathic megaesophagus?
That's often more guarded. Not necessarily poor, but guarded. Because success depends so heavily on that lifelong dedicated owner management. The elevated feeding, the right food consistency, managing complications, it takes incredible commitment. Strictures can also be guarded because they often need repeat dilations.
And the prognosis is poor if.
If it's caused by a severe, untreatable underlying disease or maybe advanced cancer involving the esophagus, those cases generally have a poor prognosis.
And just to reiterate those complications.
The sources definitely circle back to them. Aspiration pneumonia remains the biggest, most frequent, and potentially fatal risk, but also chronic malnutrition, severe weight loss, cachexia, ongoing esophagitis, which can lead to more strictures, and just generally a poor quality of life if it's not managed well.
Wow, it really is quite a journey, isn't it? Starting from what seems like a simple act of a pet bringing food up and uncovering this whole complex world of esophageal function, nerve pathways, varied causes, and intricate management. This dive into the sources really highlights how vital that initial distinction between regurgitation and vomiting truly is.
It absolutely does. It's a prime example of how one clinical sign can signal a major underlying issue. Recognizing it as regurgitation, understanding the potential reasons why based on material like this, and then pursuing the right diagnostic and management plan. It's all essential for the pet's health.
This material makes that crystal clear. And it leaves you with a final thought to chew on, doesn't it? Based on everything we've pulled from these sources. When you consider how common idiopathic megaesophagus is maybe the most frequent cause of regurgitation and how it demands such intense, daily, lifelong commitment from an owner, especially that meticulous elevated feeding routine, maybe the biggest factor in whether that pet does well long-term isn't just the diagnosis itself, but actually the depth of that human dedication to providing that very specific, consistent, supportive care day after day.
That's a powerful takeaway. The human element in managing chronic conditions like this is absolutely critical.